So welcome back to the Dr. Doug Show. Today I'm going to do another study review. This is an article that was written recently that is a review of osteoporosis. And this was published in the Journal of the American Medical Association, or JAMA. And this was just published this month. So I think it's critical that we, as people who want to improve our bone health, understand what's happening in the medical system. And these review papers are an updated recommendation, review, discussion around all the things that are on this topic. This paper literally is called Osteoporosis, a Review. And so I'm going to go through all the details of this. I'm going to share my screen and I'm going to talk about some of the specific sections in here that are relevant to you as my audience who are interested in improving your bone health, either because you have osteoporosis or because you are interested in bone health through the lens of longevity and you want to understand what's happening in the conventional medical model and how you may want to think about it if you want to avoid some of the traps that I'm going to talk about. Okay, so this is the study, and again, it's called Osteoporosis, a Review, and it was published in JAMA, and you can see that it was published June 30th, 2025. So it was literally like a month ago. So as usual, when I talk about articles, you can see that this is a kind of a lengthy abstract that have a lot of details in here, and a lot of people only read the abstract or only have access to the abstract. So I just want to point out here, when you talk about the conclusion of the abstract, I'm going to read this. I'm going to talk about why I think this is very short-sighted. So they say that in conclusion, in relevance, osteoporosis is a common condition among older adults that leads to an increased susceptibility of fracture, which is associated with substantial morbidity and mortality. All true, right? We know that that is the fracture risk is the thing that we're worried about. And yes, it's absolutely life-changing. And then they go on to say in the second sentence, anti-resorptive agents such as bisphosphonates or denosumab, that's Prolia, are recommended for patients at high fracture risk. And we'll talk about what that definition means. And then they say anabolic treatments with parathyroid hormone analogs, such as teriparatide and abaloparatide, that's Forteo and Tymlos, and sclerostin inhibitors, such as romosozumab, that's Avinity, can be considered for very high-risk individuals. So this is the conclusion of this paper, right, in the abstract form. And the only thing they say is osteoporosis is a bad thing, and these are the two different drug classes you should consider. What concerns me about that is that there's no discussion here, even in the conclusion of, what is lifestyle. They do talk about this later, but I'm going to show you how little the discussion is around lifestyle, around nutrition, around exercise, around hormones, around all the things that we know are powerful for bone health. So this really puts into context what your doctors are seeing and what your doctors are reading about osteoporosis. Okay, so going through this, again, I'm not going to read the whole thing. Obviously, I'm just going to hit some highlights. They mention here in the very beginning, in the introduction, they say osteoporosis management focuses on the prevention of fractures rather than treating low bone mineral density. That's actually a relatively profound statement because most people are looking at the DEXA, the T-score, bone density, and they're missing the big picture, which is we want to worry about preventing fractures. And that's why a lot of the things I talk about, understanding bone quality, fracture risk, et cetera, so much more important than understanding just what your BMD is. So I hope that makes sense. So then they go into the methods. They basically reviewed everything. They found 1,237 articles were identified that they could work from. So 98 articles included. So this is a lot of data, some randomized controlled trials, some meta-analysis, some guidelines, some position statements, observational studies, et cetera. This is a massive review of the literature. And these are the types of papers that get published in JAMA. So then they lead into the discussion of this, talking about that. And actually, I really love this statement. They compare what adults need to do with their bones versus what kids need to do with their bones. Kids develop bone in a different way than adults, right? We maintain bone differently than we grow it. They say that the primary process for preserving bone mass after skeletal maturity involves resorption of damaged and older bone, followed by formation of new bone or remodeling. This is the concept of metabolic balance that I'm always talking about. We are always breaking down, always building up. In fact, on average, an adult will replace the entire skeleton in about a decade. So we're always breaking down, we're always building up, and we need to do both. And this is some of the challenges that I have around the recommendations to use drugs long-term, because it certainly slows that process down. So then they have a really nice paragraph here on risk factors for osteoporosis. And I'm actually going to run through this because when we talk about the 4R method, right, we're talking about recognizing why you're losing bone, reversing those causes of bone loss. Recognizing why you're losing bone could definitely be looking at the risk factors. I'm actually going to run through this because this is actually pretty good. The first thing they say is genetics. Now, of course, we can't change our genetics, but we can know if we have high genetic risk. Generally, if you know your parents, you know that they had fractures or osteoporosis, grandparents, et cetera. And also now there are genetic tests for this. And then they go into nutrition. They go into it in more depth. This is nutrition as a risk factor. But essentially, all they say in here is nutrition, such as adequate calcium intake. That's it. So they don't actually go into nutrition much as like what you could be missing. They say physical activity is lack of physical activity, rather, is a risk factor. Levels of estrogen, progesterone, testosterone, and growth hormone, all potential risk factors and regulators of peak bone mass. So that's really important. Premature menopause or premature ovarian insufficiency. So premature menopause, either surgical or through POI. They talk again about nutritional deficiencies, but they're really talking, they only say e.g. vitamin D and calcium. Again, missing a big picture here for me. Low body mass index, which would be a nutritional deficiency frequently. They say BMI less than 20, weight loss, immobility, presence of certain comorbidities. That would be Crohn's, ulcerative colitis, rheumatoid arthritis, chronic liver disease, kidney disease, et cetera. Then they go on to talk about medications. This is really important. So anastrozole, letrozole, these aromatase inhibitors, current smoking, high alcohol consumption of over 3 drinks per day, et cetera. So that's a kind of a long list, but they're really short on some of the lifestyle things. They do get into that a little bit further, but more in the form of treatment. And then they get into the clinical presentation. So this, again, is kind of aimed at doctors, but I think it's important that we understand it. And one of the things they talk about here that I think is a little bit concerning for me as a clinician is they are now expanding the idea of what fractures should be considered related to low bone density. What I mean by that is that historically, the definition of fragility fracture was a fracture with a quote unquote low trauma or low energy mechanism. That'd be like a fall from a standing height, right? So if you were to break your hip by falling from a standing height, that would be a fragility fracture. Or maybe your hip actually broke and then you fell. That happens not infrequently. But what they're saying here actually is they say that, and I read this study, they say that actually we should be considering fractures from high trauma, such as falling down a flight of stairs, having the same association with reduced BMD. And in the end, they go, could be prevented by the same medications used to reduce osteoporotic fracture. So they're kind of laying the pathway here to say we should be treating people who had an injury from a high energy mechanism or a high trauma. So really only then saying people that had a very high energy trauma, like falling off of a roof or high-speed car accident, as people who really aren't at risk for a recurrent fracture. So a little concerning because I think this is pushing to expand the role of using these medications. So then they talk about diagnosis and screening. And I think what's interesting here is that they actually say that most clinical guidelines recommend screening for osteoporosis in postmenopausal females and males older than 50 years old. That's not really what we see in clinical practice. There are doctors that do ask about risk factors. And again, I'm going to go over some risk factors. And if you listen to the ones that I just talked about, we all have risk factors, I think. But they say older than 50. And I actually looked at some of these guidelines, and they do actually say that. But this is different than the USPSTF, which is the United States Preventive Services Task Force. The USPSTF is making recommendations for when we should be screening as clinicians for different things. And the USPSTF does not say over 50. They say 65 for women and 70, maybe not for men. And so I see clinically that people aren't following this, but I think at least it's good that these are in some guidelines. Now we just have to educate physicians that they need to follow them. Then they go on to talk about fractures. Now, this is an important statistic that if you haven't heard this before, hold on to your bootstraps, because this says that approximately 70% of osteoporotic fractures occur in females and males who do not have osteoporosis. 70% of osteoporotic fractures occur in females and males who do not have osteoporosis based on bone mineral density levels. It's a big number, right? And this is why it's so important to understand that it's bone quality, fracture risk, not just BMD. We can use BMD to help stratify fracture risk, but it's so much more than that. Then they talk about FRAX, and if you're not familiar with FRAX, you could look that one up as a way to predict fracture risk. And it's an online tool. Just look up FRAX, F-R-A-X, and you'll find it. All right, so then they get into treatment. Now, this is a really important area because this is what your doctor is going to read when they say, oh, I want to update myself on osteoporosis. I'm going to read this paper. Here we go. Here's lifestyle. So they say general lifestyle measures should be encouraged in all adults to prevent fractures, including maintaining a BMI higher than 20. Cigarette smoking and daily alcohol intake should be avoided. Reducing fall risk through exercise and multifactorial interventions should be considered in older adults. And that's about it. Now, they do go into some detail on some of these things, but that's lifestyle. And while I agree with some of those things, like don't drink and don't smoke, and you should have a BMI higher than 20, I think there's a lot of room for more discussion here. So let's see what they say about exercise. They talk about several different studies. Only one of them do they mention exercise improving bone mineral density. The rest of them, they're talking about preventing falls, which is important, don't get me wrong. But there's not a lot in here about utilizing exercise as a primary tool to help improve bone metabolism to potentially reverse osteoporosis. Basically just saying you can do this to help prevent falls, which would help prevent fractures in theory. They also talk about balance and functional exercises in an elderly community, which again, there's value in this, but I think it's missing the big picture. Then they get into nutrition. And again, they're talking about dietary calcium and vitamin D from food sources. And yes, okay, that's valid and important, but they don't talk much, actually at all, about protein, how much protein you should consume, how many calories, what should the goals look like. All they're talking about is where to get vitamin D and where to get calcium through food, which again, valid discussion, but missing the really, really big picture here.
So you guys know I'm always looking for unique supplement combinations. And I was pretty excited when I saw this one from 4Well called Advanced Formula Saw Palmetto for Men. Now, the company 4Well has only a couple of products, and they only put out unique formulations like this one, which has DHEA, saw palmetto, and ashwagandha. Now, you've heard me talk a lot about DHEA before. So DHEA is great because it's an androgen. It's good for your brain, for your bones, testosterone balance, body composition, muscle mass, etc. But especially at doses like this at 50 milligrams, we see androgenic side effects in some of our patients, and that includes me as well. So there would be like acne and hair loss, etc. So that's why they combine it with saw palmetto. Saw palmetto is a 5-alpha reductase inhibitor. Actually works the same way as some of the drugs that are used for hair loss. It blocks the conversion of testosterone to dihydrotestosterone, which could be a major contributor in many cases. So I've actually started taking this product, and guess what? No androgenic side effects. Now, the third ingredient, ashwagandha, is a really popular adaptogen. It's in a lot of products because it can help balance cortisol. It helps with hormone balance, testosterone balance. It's really popular with men and libido support products, etc. So ashwagandha is never a bad thing to add in. It probably adds just a little element of calming to the whole thing. So if you've tried DHA in the past without success, I would consider trying this combo out. And if you click on the link or use the code Dr. Doug, the number 4Well, Dr. Doug 4Well, you'll get 10% off.
And then they go through this like pretty extensive review of these studies on calcium and vitamin D. And I'll just save you me reading these, and I'll tell you that the short summary is these studies all show that calcium supplementation and even vitamin D supplementation did not have an effect of reducing fracture risk. So say that again. Calcium and vitamin D in these really big studies did not reduce fracture risk. So it's more than a supplement thing. And this is why from a nutrition section, I would want them to talk about protein and high quality foods and all the things that you should potentially eliminate from your diet rather than just saying calcium, vitamin D, and then showing that supplements don't work. I think, again, missing the big picture here. Then they go on to talk about the idea that the Endocrine Society does not recommend even testing vitamin D levels. And again, I think this is short-sighted. We need to know if we're vitamin D deficient, because if you're vitamin D deficient, there's no way that you're going to actually build bone. You have to have vitamin D to utilize calcium that you're consuming either through diet or supplementation. And then they talk about the Bone Health and Osteoporosis Foundation, which used to be called the National Osteoporosis Foundation, and that they say we should be measuring vitamin D levels in anybody that has certain medical conditions, or has limited sun exposure, or after bariatric surgery, or has some kind of malabsorption syndrome. The truth is that we are probably, not all, almost all of us are sun exposure deficient, meaning that we mostly live indoors. We mostly live under, UV blocked light behind windows, in the car, whatever. Very few of us are actually getting adequate sun exposure. So all of us, I think, should be checking our vitamin D levels. I don't think there's anything wrong with that. It's not particularly expensive. And then they go on to say that a daily intake of 800 to 1,000 IU is adequate for most adults with osteoporosis. I actually disagree with that. I think it's probably closer to 3,000 IU. We're measuring blood levels, and I can tell you that consistently, most people need between 2,000 and 3,000 to maintain adequate vitamin D levels, and usually more than that to actually get adequate vitamin D levels. And then they go on to talk about drugs. Now, I'm not going to go into great detail here on the drugs, But I do want to talk about the kind of different classes that they put out here. They talk about oral bisphosphonates. They talk about IV bisphosphonates. Remember, these are the drugs like Fosamax, like Reclast. These are the drugs that poison osteoclasts, stop them from working, and it shuts down bone metabolism. They said in the beginning that in order to maintain your skeleton, you have to have good bone metabolism. This shuts it down. I'm not saying we shouldn't use these drugs. I'm just saying that from a long-term perspective, we should consider what these drugs are doing to the bone. All right, sorry to interrupt this article review, but if you are listening to this because you are trying to improve your bone health, because you are on a bone health journey and you haven't been to our masterclass, please come to our masterclass. That's where I go through the top 5 mistakes that we see people make all the time in their bone health journey that's slowing down or preventing their success. So if you haven't seen it, please come see it. Look for the link in the description on YouTube, or you can visit our website at osteocollective.com. So they talk about these risks of osteonecrosis of the jaw and atypical femur fracture, and they put in here these really, really low numbers, 0.2 to 10 per 10,000 patient years, which is that's a very rare risk. I recently talked about an article that demonstrated that the rate may be significantly higher than this, especially for those that are also using steroids. So I think we're probably not seeing all of these that are happening, especially osteonecrosis of the jaw, because they're not being reported, because they're being identified by dentists who are not reporting them in the same medical system. And then they go on to talk about Prolia. Prolia, very popular drug, right? So you do an injection every 6 months. It's very easy, works differently. It actually stops osteoclasts from becoming osteoclasts from the precursor cells, which then again changes bone metabolism significantly, shuts down osteoclasts, which then shuts down osteoblasts. So again, you're very much limiting bone metabolism. And then the challenge here is that there's some potential side effects, but you have these same concerns around osteonecrosis of the jaw, atypical femur fracture, and shutting down bone metabolism. So you probably can't use this forever, although there's more data on denosumab or Prolia than there is on bisphosphonates over 10 years, because we see on the bisphosphonates that if you go over 3 years or over 5 years, then these really concerning risks start to increase. So they make a recommendation in here, to use what's called a drug holiday after a bisphosphonate after 3 years or 5 years. And then if you are still at high risk, which almost all of them would be, then consider some kind of additional drug therapy. Then they go on to talk about estrogen receptor agonists. This would be raloxifene. Or Avista is what it's called, the brand name. And this has really lost favor because it really seemed to have a bigger impact on spine over the hip, which you would actually expect based off of the mechanism. And it works through estrogen receptors, kind of like estradiol, but it's selective. So it's called a SERM, selective estrogen receptor modulator. And it has some pretty nasty side effects and pretty high rates. So we've actually played with this a little bit in practice. I haven't been impressed with the results, and I've been unhappy with the side effects. So I don't use this drug anymore. I think there might be a role for it, but the side effects are real. The risk of blood clot is significantly higher. Then they talk about the anabolics, and they kind of go on to say, the anabolics have these great numbers associated with them, reduction in spine and hip fractures, but there is a concern around how long you can use them, and then you have to use a bisphosphonate or Prolia afterward to maintain that bone loss. I disagree with that because we use these in a different way, right? Our goal is to create a comprehensive program that can help to improve bone metabolism, increase bone density, bone quality, potentially reverse osteoporosis. We sometimes use these drugs to help to push in that direction. And then when we have patients come off of these drugs, they don't lose bone because they're doing all the things, frequently including HRT, but all the lifestyle stuff too. So I don't think that you have to use bisphosphonates and Prolia afterwards, but this is the recommendation because if you don't do anything, of course, you're going to lose the bone. And then they go into talking about Avinity. And again, Avinity has these great numbers of reduction in fractures of both spine and hip fracture. But you can only use it for a year, right? So then they say use Avinity and then go on a bisphosphonate or a Prolia. And then they have this whole section on recommended therapeutic strategies. Now, the problem here is that you can kind of get a sense of the cognitive challenge that is trying to figure out how this works in the long term. And this is the biggest issue I see with the drugs is that if you're using these as a primary tool, which the guidelines recommend you do, you run into a problem after about 10 years or maybe 15 years because we don't have data on Prolia after 10 years and there's concern for side effect profile going up. You can't use the bisphosphonates for more than 3 or 5 years. Then they have to take, 3 years or 5 years off. And they actually have been saying here, like nobody knows how long that holiday should be. you could consider throwing an anabolic in here, but then they actually very specifically say don't use an anabolic after coming off of Prolia because the risk of fracture goes up. So the doctors are really kind of tied here, and they get really confused by these recommendations because there are not clear recommendations on what to do with drugs in the long term. They are fine to use in the short term with the understanding of the risk. But what is the long-term plan? That should always be the question when it comes to drug therapy. Then they go on to talk about monitoring, and this is kind of frustrating because they say repeat measurements of BMD can be performed every 2 to 3 years. So that's a long time. And they also go on to say, you should be looking at your fracs after 3 to 10 years if you're not under drug therapy. That's way too long. We need to be looking at this more frequently. And one of the things that we talk about very often on our platform is that we need to be looking at bone health as a biomarker of health span, meaning we need to be looking at imaging, probably not more than every 6 months if you're using REMS, DEXA every 12 months, because it just doesn't change that quickly. But we want to know if it's changing in the wrong direction or right direction. And then we want to be using bone turnover markers. We want to be getting a sense of what's happening with our bones, because if our bones are losing bone, something's wrong and we need to do something about it. So again, I think it's just a different way of looking at it. And I would love to work with the Bone Health and Osteoporosis Foundation to kind of change the way that we're looking at bone from an imaging and from a blood work perspective, because we can use bone as a biomarker of health span. We're just not doing it now. Right now, we're looking at bone only through the lens of fracture risk, only through the lens of preventing fracture for our elderly population. I'm not saying that's not important, but I think there's a bigger picture here that we should consider. So the last thing I want to talk about here is the definition of high risk of fracture or very high risk of fracture. Because if your doctor is going to follow these guidelines, they're only going to recommend the anabolic drugs for someone who is at very high risk of fracture. And I actually created a little spreadsheet here, not a spreadsheet. I actually created a little diagram here to kind of help guide you, because it's a little bit confusing. And even if you look in here, they talk about the risk factors that put you at high risk, but it's still not actually very clear, I don't think, in here. I actually looked this up elsewhere. Okay, so what you can see here is this flow chart that I created. And basically, it starts at the top and say anyone age 50 or over. Now, I would actually like to include people age 30 or over, but let's just follow the guidelines and say age 50 or over, or postmenopausal women. So then the first question to ask yourself is, have you had a fragility fracture? Now, again, a fragility fracture is a fracture of the hip, the spine, the pelvis, the upper arm. Some people include the wrist, does not include hand, does not include the foot, technically doesn't include the ankle either. So if you've had one of those fractures from a low energy mechanism, that's fall from a standing height. And according to this article, also really concerning if you even had a high energy mechanism like falling down the stairs. Okay, so yes or no? And if the answer is yes, automatically you are at high risk, because we know that the biggest indicator of a subsequent fracture is a previous fracture. So then you're already at high risk, and then you have to just ask yourself another question, but I'll come back to that. So then if you haven't had one, then you say, okay, is your T-score less than negative 2.5? If the answer is yes, you technically have osteoporosis, and by definition, that makes you high risk for fracture. Okay. This is according to their guidelines. If the answer is no, then you say, okay, is your T-score between -1 and -2.5? Therefore, if it is, you have low bone density or osteopenia. We use the word low bone density now. If it's not, then you have normal bone density and you are low or moderate risk. And then they say consider lifestyle intervention, which I think we should all be considering a lifestyle intervention. Okay, but let's say the answer is yes, you have osteopenia, low bone density, you do your fracs. So you take your T-score, you put it into fracs, and it asks all the other questions. And if you are low risk by fracs, meaning less than 3% hip, less than 20% major osteoporotic fracture in the next 10 years, then you are low to moderate risk again, and you should consider lifestyle intervention only. If you are over that based off of fracs, the answer is yes, and you are again high risk. Okay, so the three ways that you get to high risk are history of fragility fracture, automatically you're high risk. T-score less than -2.5, automatically you're high risk. If you have T-score of greater than 2.5 but less than 1, and a frac of greater than 3% hip, greater than 20% major, then yes, you're still high risk. And then of all the high risk people, then we ask for additional clinical factors. Do you have the use of glucocorticoids or steroids? Do you have rheumatoid arthritis? Do you smoke regularly or drink greater than 3 drinks per day? Genetic history, parent with a hip fracture, BMI less than 20, or a known cause of what's called secondary osteoporosis, like a parathyroid tumor. If you have any of those things, then you are very high risk. And then other high risk people, if you have had a history of multiple fragility fractures, or if you have a fracture plus a T-score of less than negative 2.5, or a T-score of less than negative 3, you are also very high risk. So it's actually pretty complicated. And off of T-score, if you're less than negative 2.5, you're high, negative 3, you are very high risk. So that could probably break that down and make it easier. So I hope this makes it a little bit more clear, but your doctor is not going to recommend anabolics unless you are very high risk. So it's good to know if you're very high risk. And then if you have osteoporosis at all, likely your doctor is going to recommend an anti-resorptive therapy, even if you have osteopenia, but you have some other risk factors. So I hope that makes it clear. Okay, so that's the review of this new JAMA article. This is what all the doctors are going to be reading who are interested in bone health. This is what's going to guide them. So here's your big takeaway. The big takeaway is if you want to utilize lifestyle, if you want to consider using nutrition and exercise and hormone replacement therapy to the maximum of their capacity for your bones, you are going to have to advocate for yourself. You are going to have to really push this with your own care team or find a care team that will do it for you. Okay? That's the big takeaway here today. So please remember that a diagnosis of osteoporosis isn't the end, but deciding to reverse it is a beginning. I'll see you in the next video.